Here are the disclosures. We have some research support from Philips Healthcare, and we will have some information regarding the use of gadolinium-based contrast agents in this lecture. So all the lectures that you've heard so far, they are all 2D imaging. For those of you who are new to MR, there is a fundamental difference between 3D imaging in MR compared to CT or ultrasound or other imaging techniques. The key difference is in conventional 2D imaging, we collect a number of phase encoding steps to make one image. When you do 3D imaging, we actually excite an entire volume for each TR. The main reason for doing that is as follows. While the scan time increases by the number of slice encoding steps that we take, the SNR increases by the square root of the number of slice encoding steps that we take. As a result, in MR for 2D imaging, we can only get about 2 to 3 millimeter slice thickness realistically. Both the black blood imaging as well as the bright blood imaging lectures that you heard before are typically 2D acquisitions. When you convert this into a 3D acquisition, you can get high spatial resolution. So there are several ways to do 3D imaging. You could do 3D imaging for morphology, function, or to increase the coverage. In this lecture, we will just look at morphology. So what I would like to do today and leave you with would be to give you a systematic approach towards building a coronary MRA protocol. When you look at coronary MRA protocol, it has a lot of different components. We'll go through them step by step. So let us look at a coronary MRA. What are the requirements? These vessels are small and tortuous. That means that we need to get a lot of pixels over a large area. That means long scan times. Secondly, there is cardiac motion with respiration and respiratory cardiac pulsation and respiration. Also, blood flow during the coronary arteries is limited to a small portion of the cardiac cycle. So our acquisition duration is limited. We need to get a large number of phase encoding steps, and we also need gating. The third thing is coronary arteries are in a very bad neighborhood. There is epicardial fat that appears just as bright as blood, as well as muscle. So we need to generate contrast between blood to muscle and blood to fat. So these are the anatomic and physiologic requirements. In MR language, they could be translated into specific requirements. So we'll see how we'll go about building this protocol. To sum up, we could say the goals of coronary MRA first one is to extend the acquisition time, and the second one is to maximize blood to arterial contrast. So now let us do a thought experiment. A typical breath hold duration for most people is about 16 to 22 heartbeats. Assuming there is 100 milliseconds of diastolic period for each RR interval, our acquisition duration can be somewhere between 2 to 3 seconds. So that translates only to about 500 to 700 phase encoding steps. Maybe you can get 1 or 2 high resolution slices. So that is simply inadequate to do coronary MRA, which covers a very large area. So as a result, we use what is called as pencil beam respiratory motion tracking. Pretty much all vendors provide this functionality. All we are doing is we are monitoring the respiratory position of the lung diaphragmatic interface, and during each heartbeat, we collect 2 sets of data. The first set of data comes from this lung diaphragmatic interface, and the second set of data is the imaging data. If the lung diaphragmatic position is in a particular location, so indicated by these blue arrows, then the data that is collected during that heartbeat is accepted. If it is not, it is thrown away and reacquired. So this process continues until all phase encoding steps required to make a high-resolution coronary MRA are obtained. So in summary, navigators extend the acquisition time beyond breath holding capacity. So we have taken care of the spatial resolution part. How about contrast? What we do is a couple of things. One is the epicardial fat. We apply a fat suppression pulse to make the signal from the fat disappear. Now we need to generate contrast between the arterial blood and the cardiac muscle. Fortunately, the T2 of the arterial blood is much longer than the cardiac muscle or the venous blood. So by applying the so-called T2 preparation pulses, we could generate huge contrast between the two. So if you look at what is the delay time that I need to apply, here is a contrast difference. When I don't apply any T2 preparation, the contrast is minimal. When I apply a T2 preparation period of about 60 milliseconds, 50 to 60, this is at 1.5 Tesla, we get good contrast. And when I apply even higher, I start to lose the signal to noise ratio as well as the images look bad. So a typical coronary MRA protocol has all these components. There is a T2 preparation pulse, to adjust the contrast. There is a navigator pulse to generate motion. There is a fat suppression pulse. And then we have a 3D TFE or a Ssfp readout. So this readout module could be any of the things that you can want to have. So there are two major approaches to getting coronary MRA in clinical practice. One is the targeted coronary MRA protocol. This is the most widely popular method to look at proximal coronary artery vessels. So this is the only multi-center coronary MRA protocol that has been published so far. I will skip through the results. So the main use for this is that the negative predictive value of this is very high. An alternative approach is a whole heart 3D coronary MRA protocol that was advocated by Charlie Higgins and actually quite successfully used by Dr. Sakuma and others in Japan. Instead of looking at a targeted region that takes time to plan, what we do here is that we cover the entire heart with a moderate in-plane resolution of about 1 to 2 millimeters. So these are very nice images that are produced, but often these are very difficult to get in clinical practice. I'll give you one example and then we'll move on. Okay, here we go. Here are the actual acquisition of a whole heart coronary MRA, which is acquired sagittally, and then we could see the whole coronary artery tree very nicely. So once this data is acquired in this fashion, then it could be reformatted as axial images, just as you would do in CT. So the purpose here is not to detect distal coronary artery disease, but primarily to look at coronary artery vasculature. So here is the coronary arteries. You could see them well, left anterior descending artery, right coronary artery, and so on and so forth. So there are three major clinical applications for coronary MRA. One is to look at proximal coronary arteries. Second, to rule out coronary artery anomalies. So these are very good indications. And the last one is to look at tissue characterization. So for example, in this case, this is a 1-month-old baby with Kawasaki disease. So you could see the coronary arteries very nicely with these types of techniques. So I think that I will skip through this thing. One of the major problems of using navigators is that the patients might fall asleep and their breathing could be an issue. In this case, you could actually use navigator drift correction. You can set your threshold where the data will be accepted to progressively vary as acquisition time proceeds. Obviously, you could couple it with parallel imaging. So I'll skip these things through. One last point, if you have a 3 Tesla scanner and if you're doing coronary MRA, the primary role is not 3D Ssfp imaging, perhaps to use 3D TFE readout so that the long TE and the long T are associated with high resolution imaging for Ssfp will be a moot point.
The question is, how successful or how good are you at ruling in or ruling out pathology as the sizes of our patients get progressively smaller?
Yep. You know, the primary concern with respect to the acquisition protocol point of view is that as the kids become smaller and smaller, their heart rates are higher. So the primary thing that we try to reduce is the acquisition duration. So instead of having an acquisition duration of about 50 to 80 milliseconds, so we might even bring this down to 30 to 50 milliseconds so that there is less motion-induced blurring. Fortunately, as the heart rate is higher and these kids are acquired under sedation, the acquisition is actually quite efficient in children compared to adults.